Frontal lift. Nicholas, page 493, EOC, page 135. Learning objectives. Upon completion of this lab session, the student will be able to do the following. Describe the ideal physiologic respiratory motion of the frontal bones, list the steps of this technique and identify the endpoint, and correctly perform this technique on a patient. The frontal lift appears to place longitudinal traction on the falx cerebri as it lifts the frontal bone from the sphenoid. While the technique is performed, the physician may feel the sensation that the frontal bone is wobbling from side to side while being distracted before it releases and is able to resume its normal relationship. The effective performance of this technique rests on an understanding of the anatomic relationship of the frontal bone to the parietal bone, the greater wing of the sphenoid bone, and the temporal bone at the pterion. The principle of the technique is 1. To internally rotate the frontals to disengage them from their related bones, 2. To lift them anteriorly, and 3. Permit them to externally rotate and widen the ethmoid notch. Diagnostic procedure. Place both hands in contact with the frontal bone such that the index fingers are aligned on either side of the metopic suture and the other fingertips contact the brow ridges bilaterally. Palpate the motion between the left and right halves of the frontal bone as you palpate the rate and amplitude of the inherent motion of the CRI. As the head moves into flexion, the frontal bone or bones should be felt to flatten anteriorly and widen laterally in external rotation. As the cranial base moves into extension, the frontal bone or bones should be felt to narrow laterally in internal rotation. Identify motion restriction. The treatment. Physician sits at the head of the table. Patient is supine. Number 1. The physician rests elbows on the table. Place the hypothenar eminences on the lateral angles of the patient's frontal bone and interlace the fingers over, but not in contact with, the forehead. Number 2. Attempt to draw the fingers of one hand from the fingers of the other, yet at the same time gripping the fingers of one hand with the other. Action of the lumbrical muscles. In this way, the hypothenar eminences exert an influence of internal rotation on the lateral angles of the frontal. Number 3. Coordinate this action with a lifting of the frontal anteriorly toward the ceiling until the lateral angles can be felt moving into external rotation. Number 4. When the frontal bone appears to be in the midline and has been released anteriorly, it is slowly allowed to settle back to its normal relationship. Number 5. Gently release the hands from the patient's forehead and reassess. Parietal lift. Nicholas, page 494, EOC, page 136. Learning objectives. Upon completion of this lab session, the student will be able to do the following. Describe the motion of the parietal bones, especially with regards to its relationship with the temporal bones. To list the indications for this technique, and to correctly perform this technique on a patient. The parietal lift appears to place transverse stress on the tentorium cerebelli, balancing the tension from right to left. Diagnosis of parietal dysfunction is performed in a fashion similar to that of frontal bone diagnosis, with the exception of hand placement, which should follow the description of hand placement in the treatment procedure here. The treatment. The physician sits at the head of the table. The patient is supine. Number 1. The physician rests forearms on the table and places the fingertips on the inferior border of each of the two parietals just superior to the squamous temporal suture. Cross the thumbs above, but not in contact with the sagittal suture. Firmly press one thumb against another, i.e., one thumb presses upward as the other resists this motion by pressing downward. Thus, the fingers will approximate and induce internal rotation of the inferior border of the parietal bones. At the same time, lift both hands in a cephalad direction towards the physician until the parietal bones move into external rotation. When balance is achieved, the physician reduces the lifting force and allows the parietals to settle back into the skull. Release the patient's head gently and reassess motion.